Sometimes a video idea comes from a question, and this is a question that was posed from a video that I shot about using old photographs for your hairline and why I don't believe that it's a great idea. You can watch that video if you want more details. This is a question that was asked whether I thought using photographs of one's family members would actually be helpful to give me clues as to your hair loss progression. I've talked about this subject in other videos somewhere in the dawn of history, so instead of trying to find that short snippet, I'll do a full dedicated video on this subject. In short, the answer is no. And the reason is that I really don't believe the genetics of a family are helpful when I'm trying to interview a patient about his or her hair loss. That may sound against the grain, and in fact it really is. In my textbook I released last year, I mentioned this, and I mentioned why that is the case. I don't even bother to do a family history. I've heard the argument, actually from one of my faculty members at my course I just ran. He talked about how it's important to do an extensive family history because if everyone goes to a Norwood 7 pattern, that there's a good likelihood or there's a higher potential for that patient to go to a Norwood 7 pattern. And Norwood 7, as a reminder, is the most advanced hair loss out there. Okay, I could see that. I mean, I definitely, if you gave me a family of 7 Norwood 7s and another family of all Norwood 1s, and I had a patient in front of me, of course, maybe the odds would favor the person that had all Norwood 1s or 2s versus a family with 7 Norwood 7s. So in theory, that could be the case. But there are a lot of other fundamental things that really make it so that I don't think that's relevant in a practical sense. So for example, let's take a case where I've got 7 family members who are all Norwood 1, 2s. In other words, they're just, first of all, very, very few Norwood 1s. Norwood 1 is almost like a prepubescent hairline. I have a few friends that have Norwood 1s. But basically a Norwood 2, which is what I am, I'm a 2 going to maybe a little bit of a 3. So 2, 3 is normal after puberty. So let's say we had a family of 7 Norwood 2, 3s, and in other words, really no significant hair loss, and a person comes in and they're 20 years old, rapidly losing hair, they're miniaturizing, they're thinning everywhere, their donor area is collapsing. Does that family history make me feel safe with this patient? Absolutely not. I mean, I'm still absolutely scared because what the patient is sitting in front of me tells me everything I need to know. Let's take the flip side. Let's take, I've got a 7-year-old guy that has a Norwood 2 or 3 pattern, very little, maybe is a little thinning in the corners, he wants that restored. So let's say it's a Norwood 3 pattern. I don't restore to Norwood 1. So let's say he's a Norwood 3 pattern. He's got just a little bit of recession. His donor capacity is amazing. And his family is all Norwood 7s. He's got 20 members all going to Norwood 7 by the age of 50. Doesn't matter. He's 70. He's got amazing donor. I can see where he is going. He's not going to lose that hair. The reason for this is that even though, and those are extreme examples, but in general, it almost never helps me. It never helps me because the genetic profile of a family is so variable in its penetration. So is hair loss genetic? Yes. Where is the genetic locus? Well, there is one like genetic locus for androgenetic alopecia found, but it's only one of many, many genes. So it's polygenic. In other words, even though it is genetic, it is actually from so many sources that we don't know. Plus, it has variable penetration genetically, and it has epigenetic factors. So there's a movie that I always cite called 3 Identical Strangers, where these 3 brothers grew up. They were triplets, identical triplets that grew up in 3 separate households. They didn't know each other until they were adults, and by a miracle found each other. And if you watch this movie, all 3 of them had different hair loss patterns. Very different. And some smoked, some were overweight. They're all overweight, but some different to certain degrees. So there's such a huge epigenetic factor. Epigenetic just means environmental factors that can influence it. I've had identical twins that came in here that had different hair loss patterns. And they're not radically different, but they were substantially different. And I will tell you that that's another indication where, yes, genetics are there, and yes, the reason you're having hair loss genetics. So there can be a very powerful epigenetic factor, and that's what I call sick hair. You can Google that, watch my video on sick hair, which, in fact, one of my colleagues, I was doing a retreat just this last weekend, and he's, I think, mid-40s, and he asked me, should he start Propecia Rogaine, and he's a little bit overweight. I looked at his hair. He didn't fit a genetic pattern, but his donor area looked miniaturizing and thinning. his top of his, sort of his, into his bottom crown was sort of off. It didn't look healthy, the hair, but the rest of his scalp looked pretty good. So I was, and I had that, you know, honestly, I was 30 some pounds overweight and I was thinning in my crown. I've restored it and it's been 15 years. I've never lost hair. I've not needed the medical therapy. So I told him, look, clean up your diet, lose some weight, use my Folli-Flow spray to help with, you know, FOLLI, FLO, it's on Amazon, it helps strengthen and thicken hair. And maybe I don't need to start medical therapy. Now, I have a very low threshold to start men on medical therapy, finasteride, minoxidil, because I think that the genetic push toward hair loss is so strong. So I don't want you to hear this video and say, oh, Dr. Lamb told me that I don't need finasteride, minoxidil. I could just use this Folli-Flow spray and all will be good. Or, you know, no. Most men need, if they're thinning and showing an androgenetic hair loss pattern, in other words, male pattern baldness, they're going to need medical therapy. But in certain select circumstances where I look at sick hair, I look at things that may be an epigenetic factor, that may be less of a genetic factor. And you sometimes get what's also called senile alopecia. My father had some sicknesses going on, and as he got older, his hair thinned. I think part of it was genetic and part of it was just his disease processes that he had. So, you know, living a very healthy lifestyle can help, but it's not necessarily going to stop male pattern baldness. You know, stopping testosterone, that's another factor I forgot to mention too, is in another video where I talk about I hate testosterone, is that your genetics could be really good, but you could be on testosterone replacement. And that could be a factor that's actually leading to problems that it's not, you know, like I had two gentlemen who were one late 40s, one mid 50s, who had never experienced male pattern baldness, and they started to lose it once they started testosterone. It was timed exactly to that testosterone. So here's this person who, if they never started the testosterone, they probably would never have needed a transplant from me, and they probably would have been fine. They may not have been. Maybe at this age of 60 or 70, there won't be. But what happens as we get older, the testosterone levels drop a little bit. That impetus, that push toward hair loss starts to also diminish. So I don't think they necessarily would have had hair loss if they had not started testosterone. Now they may need 2 to 3 or 4 transplants over the rest of their life to manage the situation because they like testosterone. It doesn't mean everyone will have that same issue with testosterone. Sometimes they won't. And so testosterone can unmask it. So you can have two brothers, both 50 years old, both with exactly genetically identical, if they're genetically identical twins, same diet, same exercise, same sun exposure, same everything, same stress in their life, etc. But one takes testosterone and one doesn't, and that one on testosterone could respond. Or you could have two genetically identical, same epigenetic factors, one's on testosterone and one is not, and they still have the same, because we don't know how testosterone influences people. Sometimes it does, sometimes it doesn't. So I know there's a long video about all these subtleties, but that's the art of understanding, of having been in practice over 20 years, that this is not a cut and dry thing. However, I will say that I rarely take a family history, and I rarely think a family history is impactful because there's so many more important variables. I always say when I look at a patient, I look at their age, whether they're on medical therapy for hair loss, testosterone, what I'm seeing on their scalp, have they had transplants, what the rate of progression is, what their issues with response to testosterone. All of that information, physical exam and history, give me everything I need to know as a prediction for the future. But the one thing I love to say is we have a cloudy crystal ball for the future. My prediction is only a prediction. It's almost like Nostradamus. Sometimes he's right, sometimes he's wrong. But we have a judgment where we look at enough data that we have a general idea of this is going to be a red flag, don't operate. This is going to be safe. This is going to be less safe. My safest is a 70-year-old guy, regardless almost of what it is, because the older you are, the longer the track record is and the clearer the history is. The unsafest is a 20-year-old coming in here thinking, okay, he's on dutasteride, he's totally safe, no problem, let's do a transplant. That's absolutely false. So this is something that I just hopefully gets you a better flavor and understanding where I'm thinking, but I probably will not take a family history from you, and that may be weird. You may have gone to 2 other consults and they did, and they think Dr. Lamb is crazy for not doing it, but I just don't think it's relevant for my consultations.